This lecture is on hypoglycemia, primarily on how to recognize hypoglycemia and how to treat hypoglycemia. This is lecture number 7 in the diabetes series of 8 lectures. Learning outcomes. By the end of this lecture, you should be able to define hypoglycemia, discuss the healthcare burden of hypoglycemia, recognize signs and symptoms of hypoglycemia, and know how to manage or treat hypoglycemia. What is hypoglycemia? Hypoglycemia is defined in your book as a blood glucose level of below 65 milligrams per deciliter. Note that other textbooks and some facilities define hypoglycemia as blood sugar level below 70 milligrams per deciliter. For test purposes, we go with below 70. Hypoglycemia is an important and dangerous complication of the treatment of diabetes. It can present as an acute or even a life-threatening emergency. Some of the causes or risk factors leading to hypoglycemia may be an overly high dose of insulin administered or an overly high dose of oral agents that stimulate insulin release. Patients are at risk for hypoglycemia when they have decreased nutritional intake or increased metabolism of glucose through increased exercise or physical activity. Alcohol can also reduce blood glucose levels by blunting the release of glucose from the liver. Hypoglycemia becomes more severe when the early signs of low blood glucose are blunted, as for example in the elderly or those who have a change in mental status. Signs and symptoms of hypoglycemia may also be blunted in patients who are taking beta blockers. Why is it important to discuss hypoglycemia? It's important to discuss hypoglycemia because of the healthcare burden that it presents. Over the years, there has been an increased rate of hospital admissions for hypoglycemia in Medicare patients. Severe hypoglycemia may result in coma, seizure, or even death. Even less severe hypoglycemic episodes could result in increased risk for fractures related to falls and motor accidents, increased risk for cardiovascular complications, and even dementia. So it is important for you to recognize the signs and symptoms of hypoglycemia. The initial signs of hypoglycemia will be a heightened sympathetic nervous symptoms. Therefore, you will see anxiety, hunger, palpitations, numbness around the lips, sweating, shakiness, and irritability. If hypoglycemia continues, the brain will be starved of glucose. So you will begin to see neuroglycopenic symptoms such as difficulty thinking, dizziness, fatigue, sleepiness, slurred speech, weakness, and lack of coordination. If left untreated and hypoglycemia progresses further, These symptoms can progress to seizures, coma, and death. So we need to treat hypoglycemia immediately. If your AccuCheck machine registers below 70 or whatever the benchmark is for hypoglycemia in your facility, you need to administer glucose gel immediately. This is how the glucose gel looks like. It looks like a toothpaste. And then you need to recheck blood glucose levels within 15 minutes. So is it within 15 minutes after glucose administration or within 15 minutes of the AccuCheck? Your book says it is within 15 minutes of giving glucose. So you oral glucose gel administration is the preferred treatment for the conscious individual with hypoglycemia. Although any form of rapidly absorbed carbohydrate may be used. Juice, soda, honey, jelly, bread, or crackers work well. Carbohydrates that contain fat, such as ice cream or chocolate, are not recommended. Pure glucose is the preferred treatment because fat may retard glucose absorption, prolonging the acute hypoglycemic event. After ingestion of carbohydrate, blood glucose levels should be measured again. If blood glucose levels continue to reflect hypoglycemia after treatment, the treatment should be repeated. Once glucose levels return to normal, the individual should consume a meal or snack, preferably with protein, to prevent recurrence of hypoglycemia. So what if the patient is unable to swallow? Meaning unable to swallow the glucose gel or the carbohydrate. In the hospital setting, if a patient is unable to swallow but has IV access, you administer IV dextrose, 25 to 50 mLs of 50% dextrose solution or D50. Follow your institution's protocol. You don't need a doctor's order to administer the D50. There is a standing order written in the facility's hypoglycemia protocol. If there is no IV access and the patient is unable to swallow, 1 milligram of intramuscular glucagon injection should be administered. Glucagon mobilizes glucose release from stores in the liver. This is how the D50 looks like. So it's possible that the AccuCheck machine may not register a number, but will display words to the effect that, excuse me, signify a critical low. Should that happen, the protocol is the same. You do one of three things: give glucose gel, give D50 via IV, or give glucagon IM. After which, you also need to call the lab and state that you need a critical stat glucose. You don't wait for the critical lab results. You need to treat hypoglycemia right away. That's the end of lecture 7 of the diabetes lecture series. Thank you.